So I just will show you two of my babies. So this is baby one and baby two. So baby one, Stas, has a beautiful facial profile. This is his first day of life. And my
Wow.
second baby, Rome, has a very deficient mandible. So when you have that deficient mandible, you get worried because Rome has definitely decreased potential anatomically from day one for the lower jaw to properly grow. So
Hmm.
this is Rome, who I was exclusively breastfeeding. The middle slide is 4 months. Yes, he's sleeping with a little bit lips apart, but you can see that the mandible is now at the level of the forehead. So basically, the mandible is behind forehead in the initial. The mandible is already at the level of glabella at 4 months, and then at age 2, you can see that the mandible is forward. He grew well because we are trying to control the environmental factors. So imagine you take Rome at day 1 and you introduce the bottle, and the bottle displaces the tongue down and the mandible more back. That mandible is not going to grow. So when you look at this very important growth chart for the upper and lower jaw, you can see that they grow the most up to age 2. And then there is a plateau between age 4 to age 10 where there is growth, but the growth is not the same as before age 2. That's why that breastfeeding and properly weaning the child before age 2 and breathing through the nose before age 2 is very critical for facial development, because you do have adolescent growth spurt after age 12 during puberty, but the velocity of growth is the biggest before age 2. Today, I use probably 80% of the custom expander. I do think the custom 3D printed expanders offer additional anchorage if you attach them to the teeth. I have had cases that had only 3D printed bands on the molars versus premolars or second molars. Cases that are very difficult to split with anything else split beautifully by adding additional anchorage to the molars. And there was no tipping because the bands and the arms were rigid. So I said, like, it's nonsense to place the screw so far back. We have to at least place it in the center of the upper jaw from the front to the back, or more anteriorly to engage the bone. If you place it to the front, I started to get split on everyone in females, any age. The age then became unlimited. And in a lot of males between age 25 and 30, and all of the males under age 25 split if you place it more anterior.
All right, we'll just dive right in, okay, Doctor?
Sure.
Okay, Dr. Marianna Evans, definite all-star in the space of adult jaw expansion, featured in James Nestor's book, Breathe. Thank you for joining me today, and it's a pleasure to have you on my channel.
Thank you so much for your kind invitation. It's a pleasure to be here today.
Yes, yes. And doctor, you have some special skills that other doctors that I've had on don't have. Namely, you're a periodontist as well as an orthodontist. So I wanted to begin by asking you this question. To what extent do the teeth affect the maxilla and the mandibular bone? And can removing wisdom teeth or premolars have an effect on the underlying skeletal bone?
First of all, we are designed to have 32 teeth in the maxilla and the mandible. And when the patient is missing, I mean, if they are born without certain teeth, the jaw is going to be smaller. Or if we extract any teeth, whether it is wisdom teeth or premolars or any other tooth in the mouth, there are going to be some shrinkage in that area, in the alveolar bone, or if we move the teeth and close that space in the whole jaw.
Mm-hmm. Mm-hmm. So
the
could we?
bone, the alveolar bone that is holding a tooth, is a product of a tooth. So once the tooth is removed, that part of the bone is going to be gone unless we preserve it with special grafting. So when we remove the wisdom teeth, we never graft because because our jaws are shrinking in general, those areas are considered a functional area. So we don't need to graft to preserve the area of the wisdom teeth. But
Mm-hmm.
if we extract teeth because we lost a tooth because of the cavity or fracture or infection, we try to preserve the bone. with grafting procedures, because we know that that bone is going to be remodeled once the tooth is removed and gone. When we extract the teeth for orthodontics and we close the space, that bone is going to be remodeled and gone. So theoretically speaking, the jaw is going to be smaller in overall volume if you close the spaces after you extract the teeth. Yes.
Right. Now, did I hear you make a distinction between wisdom teeth extraction and other tooth extractions? Did you say something about wisdom teeth not being functional and so it's different? We don't have to worry about grafting after wisdom teeth are removed. Can you elaborate on that?
Sure. We today, after industrial revolution, our jaw structures are shrinking because we are not loading them enough during growth or in adulthood. And that's why the majority of people today just don't have room for the wisdom teeth. Usually we extract them when they are impacted, when they are crowded, when they don't have enough room in the oral cavity to function to the same level as other teeth are functioning in the bite, in occlusion. So the reason why we don't graft those areas, because either we extract wisdom teeth that are crowded, and that area is not going to be considered functional after they are lost, because we don't need those, we are not going to replace those teeth with implants, or because they have been impacted.
Mm-hmm. Have you ever engaged in orthodontics in which you've tried to save wisdom teeth by uprighting them if they were impacted or by making space to allow them to erupt healthy? Is that something that's worth doing?
So when we have, there is today a small percentage of patients, including myself, that has wisdom teeth in erupted into the oral cavity in full function. So when the patient comes for orthodontic intervention or for the dental care, and those teeth have no periodontal issues, that they are in normal functional bite, I don't think there is a reason to remove them. We only remove problematic wisdom teeth. But if you have a growing child that presents to us at age 6 or under age 6, where we still have the potential to guide the facial development and allow the jaw to grow to the maximum potential, of course, we want to allow 32 teeth to erupt into the oral cavity in normal function as it was for thousands of years.
Mm-hmm.
If I have a patient that lost for whatever reason, or never had for developmental reasons some of the teeth, and I can preserve and move the wisdom teeth into the function, of course we are going to keep them. They are important teeth. The only reason to remove them if they don't have any space and they can cause damage to adjacent teeth and structures.
Right. Let's say you're presented with a 22-year-old adult, male or female, who has slightly impacted wisdom teeth. Every other dentist they've seen says, oh, just remove them. They're not causing you a problem now, but they might someday. Is it possible to use a skeletal expander like MSE to make space to save those teeth and then put a brace on them to upright it? Or is that a futile orthodontic challenge that's not even worth doing?
Yes. So that's an excellent question, because a 22-year-old patient is basically a patient where the jaw is not going to grow anymore. It may remodel vertically, but it's not going to grow horizontally, and it's not going to grow sagittally from the front to the back. It's considered adult, whether it is a male or a female. Maybe there is a little bit of residual growth would be left in a male, but not in a female. So if you have a situation like that, you have to try to understand that there is a difference between saving, if you expand the patient, saving wisdom teeth in the upper jaw versus the lower jaw. When we expand upper jaw, it's not only going to get wider, but it also is going to get longer at the level of the arch, at the level of the teeth. Something we call in orthodontics as arch perimeter, arch length is going to increase with expansion. That means that you can move the teeth into the diastema space. So all of the teeth from the back to the front, once you create a large enough diastema, will be moved forward. And as they moved forward, you create room for the wisdom teeth. If you do it all the time, it happens a lot. So for the maxillary wisdom teeth, potentially expansion can make enough room so we can save them. But in the mandible, it's another story. Potentially, once you expand the maxilla, and if the maxilla was deficient, mandibular teeth always grow angled in. And once we expand the upper jaw, we create room or lateral overjet to upright mandibular teeth into proper occlusion with new position of the maxillary teeth. So once those mandibular teeth are uprighted, it's very easy to create space for crowded lower anterior teeth. But it is not always, or I would say in the majority of the cases, it's almost impossible just by uprighting mandibular first and second molars and premolars to create enough space to keep the lower wisdom teeth in normal function without inflammation if they are blocked out.
Understood.
So it is the upper jaw that has a potential to save wisdom teeth if you expand in adult of any age. But in the mandible, depending on the angle of the lower jaw, the higher the angle in terms of the angle between the ramus and the mandibular body, the less likely you will be able to save those teeth. They will be more blocked out. And once you extract the mandibular wisdom teeth, then the maxillary wisdom teeth are not going to be in function. Then you have to ask yourself a question: what is the reason to keep them? So if you have a patient that can maintain those wisdom teeth very clean and floss and brush the area, maybe it's worth keeping them, but they will not be in function and they have a risk of erupting and causing some interferences into the bite.
Wouldn't they be worth saving just because they serve as sort of like a footing of the foundation of the upper teeth? Like I've often used the analogy on my channel that the wisdom teeth are like concrete footings that hold everything forward. Even if they don't have function, as you say, in occlusion, don't they still preserve the length of the maxilla?
I think the answer is yes, but the true answer is theoretically yes, but we don't have the research to say either way. I don't know. I haven't really seen that teeth are drifting back if the wisdom teeth have been extracted. You will definitely see a drift of the anterior teeth back if you lose the first molar. But we don't observe it with the wisdom teeth. So unless we do a study, it's a nice theory and it's very logical. It makes sense, but it needs to be supported by research.
Of course. Do you have any hypothesis why we don't see the upper teeth drifting back with wisdom teeth extraction?
I think because they are a little bit positioned like kind of in the corner of the upper jaw where it rounds back, and there are a lot of muscles attached to the area that kind of fill the space once those teeth are removed. But in the same time, when you look at the modern faces, like over the last 100 years, like our faces of the last 100 years versus the pre-industrial skulls that did have 32 teeth in function, those wisdom teeth were positioned more anteriorly than they are positioned today in the patients because the whole jaw is just not growing forward enough. So I think it is a theory that I think that it is very logical, but I would say that I cannot say that it's right or wrong because we don't have any science behind it.
Now, you had access to that Morton skull collection, which maybe fill in my description better, but it's basically a collection of skulls going back centuries where you're able to use that skull collection to show how facial structure and cranial structure has changed with time. And so, can you say resolutely that skulls from centuries past always had 32 teeth?
Well, we know that the environment is going to affect your oral health, and I cannot state that everyone uh, before industrial revolution hundreds years or thousand years ago had wisdom teeth in function, but I would say the majority of population had. So when we looked at the collection is very diverse. That it has skulls from all over the world, and if you ask the question if all the skulls had wisdom teeth in function, I would say probably not. But some of them, those wisdom teeth just didn't have the chance to erupt because the life was lost before age 20. But for the purpose of our study, we selected all the skulls and that had 32 teeth either in the bite or room for the 32 teeth to be in functional occlusion. So we selected the skulls that are the most natural skulls with natural occlusion. Definitely, this was the majority of the skulls. There was maybe like 1% of skulls that had some crowding and had impacted wisdom teeth, but the majority of the skulls did not.
Mm-hmm. Do you think that there's an epigenetic phenomenon at play where even if a child born to parents who have deficient jaws has perfect environmental stimuli, like, as you put it earlier, load on the teeth, that that child will still have imperfect jaw development because of genetic inheritance from the parents' bad jaws,
Mhm.
because of their environmental miscues?
The child with deficient jaws that are genetic already has a bad foundation to achieve full growth potential of the face. But I think it also, if you do something in a younger child, you still have the opportunity to reverse it to much larger extent than if you start doing something after age 7.
Mm.
And more than 60% of the facial skeleton is almost adult size. So I think genetic component is very significant factor today in anatomy and growth of the face. But I think we have also the opportunity to change the trajectory of growth if we do early intervention. But early intervention does not mean orthodontics under age 2. I mean, we need to do things that we have been doing for thousands of years. That means breastfeeding, properly transitioning into the solid foods, not introducing pureed foods, but actually hard foods that the child can suck on, and put some load on the gum pads and erupting primary teeth and allow the jaws to grow.
Mm-hmm. Mm-hmm.
We
And
know today that the jaw growth has everything to do with function. If
mm-hmm.
you don't have proper tongue placement, if you don't have the loading at the level of the teeth and gum pads in infants, then the jaw is not going to grow. And the most critical time for the growth of the jaw, where both upper and lower jaw grow the most, is actually under age 2. It's
Mm-hmm.
before we can do something orthodontically.
Wow.
Once you miss that window or you have a bad start because of the genetic component, it's very difficult to reverse and catch up after age 2.
Mm-hmm. After age 2, when it's time for or when it's needed for orthodontic intervention for a toddler,
Mhm.
do you think that tooth-borne expanders are appropriate for toddlers and children, or do you think that skeletal bone-borne expanders are better for children just as they are for adults?
Well, in children under age uh, 10 or 9, I think it's totally normal to use teeth for expansion. There is no need to use bone anchors. I never use anchors under age 9 or 10. But I design expanders so they are very retentive on the primary teeth. And I try to use as minimal as possible permanent teeth for expansion. So ideal time to expand the jaw is actually in early in established actually primary dentition or very early mixed dentition. So when I have a child that is 4, they have mature roots in the primary molars. So those roots are solid in the bone, and I think those are excellent anchors to use for expansion. If I have a 6-year-old child, I, as a periodontist, don't recommend exclusively using the first molars, permanent molars for expanders, because the first molars erupt at age 6, and those roots are not fully periodontally mature. So as soon as the first molar erupts, you put strong orthopedic forces on those molars, they are going to tip. So when I have a 6-year-old child, I think it's still great age to expand. And the sixes erupted, I will use them for expansion, but I will also utilize the E's and D's, which are primary molars, with still good root formation, mature root formation for expansion. So I will use both sides of the maxilla with like 6 teeth as one unit to get as much skeletal expansion as I get. If you take a 9-year-old child, those primary molars have lost at least 50% of the root. So all the forces that you are going to apply to the teeth at that age, if you use the primary molars and if you use the permanent molars, are going to be on the permanent teeth, and you will get very little benefit from anchoring against the primary teeth unless they are ankylosed or fused to bone. So that's why sometimes if it is age 9, I tell the parents that we kind of missed the window to get good skeletal expansion with the tooth-supported expander. And some of these children may not be ready for a bone anchor expander because the teeth are erupting. And I like to use like a special acrylic type implant-assisted expander for young adolescent patients. So you may be able to use MSE with additional like 2 implants and bands on 6s, or sometimes if you still have enough room for the teeth to erupt and there are no airway issues, sometimes it is better to wait until they are in the permanent dentition and do the implant assisted expander at age 11. But I think it's nonsense to use implants in a 6-year-old or 5-year-old. Basically, we have technology today to utilize teeth to expand young children, utilize teeth for anchorage with 3D printed or acrylic expanders that offer very good anchorage and stability and very nice opening of the bone.
And when you use teeth as anchors in a 6 or a 5 or a 6 or a 7-year-old during that special window that you described, are you actually getting a diastema? Are you splitting the maxilla, or is there some other growth mechanism occurring on the alveolar side?
When we talk about skeletal expansion, whether it is adults or children, that means that we are opening mid-palatal suture at the minimum. Usually, if it is done without surgery, and in children expansion is done without surgery, that means that we are opening mid-facial sutures. So the whole mid-face is going to have a change at the level of the sutures. That means that the mid-palatal suture should open. That means that some of the frontonasal sutures are going to be remodeling. Sometimes children have even patent suture between the nasal right and left bones. That suture will open, and also zygomatic or temporal sutures will open. And we have CBCTs to support it. If you use some of the, but I also use palatal special palatal plastic shields to allow that optimal skeletal expansion actually to happen. If you just use the teeth and there is a space between the screw and the palate, usually you also will get banding of the alveolar bone and tipping of the teeth. Not all of the expanders are going to have no or minimal tipping. Some of the expanders will have more tipping in the teeth, whether it is a young child or adolescent patient, and very minimal sutural openings. And some expanders will have a lot of sutural openings with very minimal tipping of the teeth. So I am shooting for the ones that will be opening the bones and will be minimally tipping and bending alveolar bone.
And is it the case that when children get maxillary skeletal expansion, their mandible will grow to accommodate the bigger maxilla? Adults don't get that benefit. Adults have to do dental tipping of the teeth to get their bite back after skeletal expansion, I believe, and you can correct me if I'm wrong. But for children, will the mandibular bone actually grow as the wider maxilla presses into it over the course of months or years with chewing?
So this is an excellent question because a lot of orthodontists just when they see that maxilla is deficient, they just expand the maxilla and they don't do much to the mandible, to the mandibular teeth. Of course, we cannot expand the mandible, but we can change the position of compensated mandibular teeth that have been growing to narrow upper jaw or deficient upper jaw. So I think it's very critical when you change the dimension of the upper jaw to upright mandibular teeth and put the patient in as optimal bite as you can. Some of the after you remove the expander, some of the change is going to happen at the level of the position of the maxillary teeth because the teeth are looking for each other. Upper teeth are looking for the bottom teeth are looking for the upper teeth. So the bottom teeth automatically will upright also slightly on their own so the patient can bite because the nature wants us to have proprioception between the upper and lower teeth. So if you give the patient more or less functional bite after you expand and they have a good tongue posture, so if they hold the tongue up or you help them with myofunctional therapy to hold the tongue up, the tongue is going to bring the mandible forward and up. And as long as the lips are together, sealed, and the tongue is up, you will have good growth of the mandible. Maybe it's not going to be ideal, but it's going to be better if you don't expand. And it's going to be better if the patient, compared to the patient that holds the tongue down and holds the mouth open all the time.
Mm-hmm.
So
Mm-hmm.
the mandibular response I see, but it 100% has to do what is the tongue going to do after expansion. If it sits down and holds the mandible open and back, it doesn't matter what you do to the maxilla, the mandible is not going to grow properly.
Mm-hmm.
But if you hold the tongue up and the lips sealed, that means that the upper and lower jaw are closed. In during no speech, no eating, at rest, then I think you have a good chance for that mandible to grow and catch up.
Mm-hmm. Mm-hmm.
So it is very growth is very functional. It has everything to do to what you do with your lips and what you do with your tongue and what you do with your teeth. If you don't eat hard foods, if you keep your mouth open all the time, if your lips are open all the time, there is no way if you are growing that your face is going to grow correctly.
On that note, what role do these habits that you're describing, some would call it mewing, some would call it myofunctional therapy,
Mhm.
basically good natural primal habits for the face, head and neck, tongue, nose, lips. What function do those habits play for adults after bone growth has stopped? Can an adult achieve a modest change in their bone structure over a 5 or 10 year period by chewing tough gums and eating real tough foods and having good oral posture? Or is it only of benefit to soft tissue in adults?
Mhm. So I think definitely there is a limit what you can achieve in adult.
Mm.
And if the adult patient grew so much vertically that they have significant strain between the upper and lower lips when they close the mouth, they can do all the myofunctional therapy in the world, can hold the tongue up, but it's not going to change the lower jaw angle. We call it
Mm.
high angle. It's not going to close. To the minimal extent, it will change the musculature, and you can even get some buttressing bone formation on the buccal of the teeth if you eat harder foods or chew a few pieces of gum every day for an hour. And if you eat jerky or anything hard, I think it's going to change the buccal bone supporting the teeth. It's going to change your definition of the face because the muscles will be more defined. But when you take an X-ray and look at the bones, I think there is no chance without surgery to change the angle of the lower jaw to the extent that you can avoid surgery.
Continuing our discussion of adults, half of the interview for children, half the interview for adults. We're halfway through. There's been a lot of skepticism in the community around skeletal expanders in adults and whether to place the skeletal expander anteriorly or posteriorly. Initially, with Juan Moon Appliance, it was posterior. Then, more recently, with the Partners Dental Expander, there's been a push toward anteriorizing it to get better bite on the harder bone. However, some people are saying that anterior is not good because you end up getting a more conical expansion, less nasal airway expansion. Casey Lee is famous for taking that position. He likes to mock some
Mhm.
of the expanders being too anteriorly placed. Where do you think a skeletal expander should be placed in an adult maxilla? Front, back, somewhere in between, or is it not a one-size-fits-all solution?
Yes. So you are kind of touching a question on evolution of the skeletal expansion in adult patients. And I agree with you that Dr. Moon originally, when he presented his protocol, he recommended placement of the screw at the level of the upper first molars, which is basically at the center of the most resistant structure in the zygomatic area, cheekbone area. And the idea was great, but it wasn't substantiated by any research. So theoretically, it made sense, but when anatomically speaking, when you look at the position of that screw in relationship to the length of the upper jaw from the front to the back, if there are any orthodontists that are listening to this podcast, I would say from the PNS to the ANS, the expander was placed too posteriorly, so there was less likelihood for you to split the thickest portion of the maxilla, which is in the front, because it was placed too far away from it. Plus, in a very large percentage of patients, the area where we would place that screw at the level of the first molars, the bone is very thin. So you have thin bone and you are off the center of maxilla when you measure the length of the maxilla at the level of mid-palatal suture from PNS to ANS. So you're off center. And this is why a lot of doctors that took a course and started to place those expanders started to get a lot of failures. I had a failure on my very first two cases when I took a course and I placed it exactly where he recommended. Then I used CBCT on every single patient, and it was before we had Partners Dental Studio helping us with planning of the CBCT planning of the devices. So I said, like, it's nonsense to place the screw so far back. We have to at least place it in the center of the upper jaw from the front to the back, or more anteriorly to engage the bone. So the goal of placing more anteriorly in the past, for me personally, when I was teaching, was to get a split, because if
Mm-hmm.
you place it too far back, you may not even get a split, so it's a 100% failure. But if you place it to the front, I started to get split on everyone in females, any age. The age then became unlimited. And in a lot of males between age 25 and 30, and all of the males under age 25 split if you place it more anterior. The second question becomes, what kind of split are you getting? Is it getting more conical, you're getting more expansion in the front, less expansion in the back, or sometimes no expansion in the back? To the horizontal palatine suture. Some patients didn't even split past that horizontal palatal suture. So the majority of the patients did get split all the way from the front to the back, but it was more anterior in a lot of patients. The question becomes, how is it going to impact the airway if it doesn't split in the back, or if it splits more in the front and less in the back? Honestly, there is no answer. We are not sure. Theoretically, again, it makes sense that you should split all the way to the back. But we didn't do the research to compare like the airflow in patients if they only open in the front or if they open all the way from the front to the back. So we have no research. We just have a good theory here. So now, so the goal was to get a split was a success, maybe like 5 years ago. You get a split and it doesn't matter how far it opens to the back, but you got a split. Now you can open up the maxilla, now you can align the teeth and you open up the majority of the nasal cavity. Some patients have a problem with breathing mainly in the anterior nasal wall. So anterior expansion is great for these patients. When it comes to sleep apnea and opening it in the back and maybe stretching those pharyngeal musculature, I don't know. I think it's open from the front to the back. I agree with Dr. Casey Lee. I have seen his cases where I didn't open parallel from the front to the back as he is claiming. So I'm saying that the claims are great, but we really need to do research to support our statements. So now we have. So another thing to consider: there are different shapes of the upper jaw. There are some patients that are narrow from the front to the back, and there are some patients that are narrow mainly in the front. So if you think that by placing that expander more to the back or more to the front will allow you to control how much expansion you get in the front, in the back, based on individual needs, I think we have the technique today where we can control more expansion in the front versus more parallel with the custom design. So I think if you want to get more parallel expansion from the front to the back, you have to go for the custom design. That means more than 4 implants for females and for males. And that means that you have to have the implants in the back of the maxilla and you have to have the implants in the front of the maxilla. But in the same time, you have to remember that the implants that are placed in the very back of the maxilla are going to be in very thin bone. And in the very back of the maxilla, and it's very difficult to explain this without imaging, we could have imaging supporting what we are talking. In the very back of the maxilla, there is warmer attachment to the floor of the nose. So that warmer attachment to the palatal bone could be stronger than your implants in placed on either side of that sutural fusion, not fusion and interdigitation between vomer and palatal segments. So if that attachment of the bone is stronger, and usually it is, than where the implants are placed, so that you will never get a split in that area. You can get a split on to the side of the vomer, which I think is still a success. So it's off the midline in the very back, and it may happen in adults with very thick bone, whether it is a female or a male. So, and or it may not happen at all, and the expansion will stop at the horizontal suture between the maxillary segments and between the palatal bone. So I think the answer is If you want more parallel expansion, go for custom design, go for more implants. But don't expect that everyone is going to split exactly parallel to the back, because the anatomy is the limiting factor today.
Mhm.
If the bone is thin, those posterior implants do not offer much to get that parallel expansion.
Understood. Are you? I'm sorry for interrupting.
Another thing to finish this, answering this question is,
Mm.
then what about surgery? So some people say that we could do
Mm.
a surgical expansion. While when you think about surgical expansion, is and the literature is very clear, a lot of all the patients will not split with surgical expansion all the way in the back. So most of the surgical expansions in patients with thick bone older than 22, if you are lucky, it will split to the back, but there are going to be a big percentage of patients that it will never split in the back, because
What do you mean when you say surgical expansion, doctor? Are you talking about piezo?
I'm talking about SARPI, I'm talking about dome, I'm talking about with ease, or with span protocol. If you do endoscopically and cut the maxilla from through the nose side all the
Mm.
way at the PNS, you may get a split there. But I had cases with also asymmetric split in that area, because the vomer attachment is so strong.
Hmm.
It's very
Hmm.
difficult to cut it even with the piezo or whatever burr the surgeon is using. So I'm just
Hmm.
saying that you don't expect that just because you do the surgery, that you with piezo you can never go that far other than like through the oral cavity. But even with piezo you may not get the full split in the back the way that you want it to split.
Hmm. Do you use the custom expander from the partner's lab, or do you
I
use the MSE?
Today I use probably 80% of the custom expander in my practice.
Hmm. And have you heard of the Facegenics maxillary expander that Dr. Ting tried?
Uh,
It's basic.
yes, I did get a sample of this expander, but honestly, it didn't make sense with the custom design that we have today. Any type of prefabricated expander is inferior to what I can offer the patient with custom. So the position of the implants, the angulation, I mean, it's nothing pre-made is going to be better than what I can offer with custom.
I
So,
think the
uh-huh. So I
yeah the
haven't tried it yet, but I have it in the box in my office. Mhm.
I think the FME people like to promote the fact that there's no molar arms. The other big criticism emerging from the way skeletal expansion is normally done is that molar arms are used, and there's concern if we're trying to anchor onto the bone, why do we have these molar arms? Maybe you could address that. What is the point of the molar arms, and can't they often cause tipping? If especially if the tads have drag through the bone and they slip.
Mhm.
Isn't that a superior way of going about expansion, is without molar arms?
Mhm. So I think the majority of patients that need maxillary expansion have also very long and higher palate, so significant over eruption of the maxillary teeth. And if you place the screw without engaging the molars, that's what I have been doing in adolescent patients with acrylic TAD expander, utilizing just TADs and palatal shields without including the teeth. That's ideal. But
Hmm.
in adult patients, I have seen when we use, and I have tried in adult patients cutting the moon expander and just using the screw, and I saw a lot of impingement on the soft tissue. When you expand adult patient, there is a lot of force being generated from the turning the expander, and sometimes just the screw alone is going to bend. So it might, even if you use the strongest screw that we have in the market, there could be some bending. So the difference between the arms in the custom design and in the moon expander is that the moon expander has very bendable arms. So they are not very strong. You can easily bend them. So if the patient doesn't open the first 5 days of turning, there going to be some shift in the teeth, because all these forces from turning the expander are going into something. They're going to go into those arms and the teeth, and there is a very high risk of taping and bending um, of the teeth with the bands when you use moon expander. The other thing is, if you use bands that are traditional bands that you see, pre-made bands with the moon expander, versus you use 3D printed that are more rigid, that don't go into proximally, I think the banding with the moon expander is going to be less with 3D printed bands. But if the patient, you have to monitor, once you deliver the expander, you absolutely have to monitor these patients weekly, and you need to know when they split. It's very important. So if they didn't split within the first 5 days, you are starting to look for tipping. Even if they split 2 weeks later, there are going to be some tipping before they split after 5 days. So if you use the Health Partners or rigid custom 3D printed expander, I don't use just in a lot of adult patients, I don't use just the arms to the molars. I increase my anchorage to multiple teeth. I use multiple arms, and those arms are rigid. So I could have an adult 45-year-old male that is going to be will have zero taping of the teeth because the whole apparatus is very rigid. So asking me a question, do we need really bands for the teeth to seat the device? I think it's a great tool, a guide to seat the device properly so you can place your implants properly based on the plan. But I do think the custom 3D printed expanders offer additional anchorage if you attach them to the teeth. I have had cases that had only bands, 3D printed bands on the molars versus premolars or second molars. And I think those ones that cases that are very difficult to split with anything else split beautifully by adding additional anchorage to the molars. And there was no tipping because the bands and the arms were rigid, and there was zero impingement on the soft tissue. So if you ask me between different appliances, you can't compare the arms of the moon to the arms of the 3D printed, because the moon arms are bendable and they will tip and change the position with the change of the position in the molars, and they will impinge. Today, with 3D printed, I see zero impingement, zero. I have not had one case with impingement on the soft tissue. And I'm talking about male patients. I'm not talking even about female patients, because the majority of my custom expanders that I started to use started in males. So now I'm transitioning and using them more in females, because a lot of my patients are traveling from far, and I can take a chance for impingement, and I can take a chance for patients to have emergency or not to split. So I would say the rigid design, the banding of the arms, the impingement from the arms, or tipping of the teeth becomes insignificant problem.
Thank you for that very thorough explanation. We're running out of time, so I have to choose my next questions carefully. The next major area of concern in the community is the aesthetic effect of MSE. Let me load up an image so that I can explain to you what we're thinking. Okay. Give me just a moment. All right, I'll just go with this. Can you see this image?
Yes.
Okay. So MSE works by anchoring into the maxilla, splitting it down here, and ultimately the fulcrum is way up here near the orbital, right? And so the expansion pattern that you get, and correct me if I'm wrong, is one where the maxilla and the zygomas kind of rotate outward, right? And it almost results in a kind of drop of the maxilla, and especially the maxilla expands more than the rest of the midface, which can sometimes result in a funny look in patients, especially patients who get a lot of expansion. This effect is exaggerated tremendously. How do you manage aesthetics when you're expanding adults with skeletal expanders, doctor?
Mhm. So I would like to correct you with one thing. You
Please.
said we get this expansion type of expansion with MSE, and it's not correct because we don't get this type of expansion only with MSE. We get this type of expansion in children. We get this type of expansion with any type of expander in adult that opens without surgery. So what you have on that slide is demonstrating not MSE type of expansion, but expansion that happens in the facial skeleton without surgery in adult or a child. So that's the expansion, that's the center of rotation of the maxilla was when you do any type of skeletal sutural opening without surgery.
Mm-hmm. Mm-hmm.
So first of all, now to answer your question, uh, about aesthetic concerns, um, we should not be expanding patients that don't need expansion. So the reason why we are expanding patients is because the patients have deficient mid-face or deficient upper jaw.
Mm-hmm.
And usually the shrinkage happens all the way from the cheekbone down to the level of the teeth.
Mm-hmm.
That type of skeletal midfacial opening is favorable for the facial aesthetics, but it
Mm-hmm.
may look very abnormal right when you open the suture before you start molding and closing the gap and start uh, finishing positioning of the teeth. So I cannot say that maxilla necessarily dropped in all the patients. So that's something that we have to really study because I don't see that all patients that it just automatically drops. But I do see a drop in the maxilla if it gets asymmetric toward the end of the expansion. That's one side, depends on what sutures are fully opening, that side will drop to in relationship to the other side. But the problem becomes with aesthetics is when the patient has pre-existing asymmetry in the upper jaw. So pre-existing asymmetry, you expand, you still open the maxilla and mid face at the same sutures. So one side will be exaggerate, like more asymmetric than the other because there is already a cant and there is already an asymmetry in the upper jaw. So you have to watch for it and you have to explain to the patient that you may be limited how much you can expand without surgery, and maybe that MMA surgery and re-angling and addressing the cant surgically is the answer for that patient. But in general, if the maxilla is deficient and the face is proportionate and you measure according to the proportions of the face and how much you expansion need at the level of the upper jaw, the face aesthetics should improve because you are improving the balance between the muscle attachment around the eyes in the orbital area. So they're going to be less squinting when the patient smiles, that less facial musculature engaged when they talk and they smile. So the face will look more relaxed and more balanced. So when I can show you case after case, not when the patient is expanded, but the patient when the patient is finished with moving the teeth and the bone healed, the face will look better. It
Mm-hmm.
will look worse if there is significant asymmetry pre-expansion and if there is asymmetric expansion that happens. That definitely could be an aesthetic effect. But if it is done for deficient maxilla and you improve the proportions between the mid face and the lower jaw, you are more likely to get the diamond shaped face and improve the aesthetics.
Mm-hmm. Mm-hmm.
It's your
And last,
house.
yes, thank you, doctor. Last question. The other big elephant in the room with expansion is mandibular expansion. How do you feel about mandibular distraction osteogenesis, MSDO, or as Dr. Yusefian calls it, DAME, or IMDO, like Dr. Kochianchich does? Do you see any type of mandibular skeletal expansion on the horizon of your practice, or do you agree with some others I've had on my channel who say it's not necessary?
It's not necessary. When you look at the we did a study on the skulls, on the pre-industrial skulls. It's not published yet, but it's in the process of being prepared for publication. And when I compare those skulls to my patients, if I look at the anatomy, the more deficient the maxilla gets, the wider the mandible gets. So in patients with severe maxillary deficiency, the mandible actually is wider at the base. It shrinks more at the level of the teeth, but the base of the mandible is actually wider. So you really have to address the mandible in patients with deficient maxilla that goes through expansion by changing the position of the teeth, by uprighting the teeth in the bone. And once you upright those posterior teeth, you make room for the anterior teeth to align without need to extract any premolars or incisors. But distraction, there are a lot of questions I have about the concept of distraction because it only goes one way. It doesn't change it's a shape problem in the mandible in patients that have deficient maxilla. And distraction just does this. It's one uh, direction widening in the level at the level of the symphysis can cause rotation and some kind of change in the condyle. It's not, it hasn't been reported, but how many cases have we really looked at to say that it's not a problem? And you have to study something like this long term. And I think the distraction, the way it's done right now, there is a risk of the inflammation, impingement on the tissue, development of gingival recession, and even losing one of those incisors is invasive procedure. So I don't think anatomically there is really indication for it. Because if you look at the CBCT, what happens to the mandible in patients that need expansion, you will realize that by changing the position of the teeth, you will get improvement in the mandibular anatomy as well. That's why it's very critical to do this skeletal correction in a young age before to allow the permanent lower teeth erupt upright like soldiers rather than uprighting at the angle. Mandibular shape is a product of the angulation of mandibular teeth. If the teeth grow this way, so will the mandible. If you allow the teeth to grow axially and vertically, the mandible is going to be more tucked in within the maxillary base and the teeth will grow more vertical, so the mandible will be more proportional and it will look like in pre-industrial skulls. If you miss the window, then you have only a chance to upright the teeth orthodontically. But distraction is very questionable, very invasive, with a lot of periodontal risks. I don't see a reason to consider it.
Then in terms of ameliorating or mitigating the balloon face aesthetic that sometimes results with MSE, where the upper looks much wider than the lower, do you think then that, based on your theory that you just suggested, that the mandible is not usually actually skeletally smaller than the maxilla? They're not both small together. It really is just the maxilla that's small in most cases, where the mandibular bone is fine.
Deformed. The mandibular bone is not fine in patients with deficient maxilla. It's deformed. A mandible is going to result in deformity of the shape in the mandible when the upper jaw is too small. This part, this is your widest part of the face. So if this face is not wider than this, that face is disproportional. Ideally, we are designed for the zygomatic width to be the widest. If the mandible is wider than zygomatic width, that's not normal. And all the anthropometric studies show about proportions of the face say that should be the widest.
And are you finding that patients now in this epidemic of underdeveloped faces, that's not the case? Their mandible is usually the widest part of their face?
Not usually. I find that both look narrower, but I find a lot of patients, and I call it like a very masculine class 3 look like this part is wider than this. So that's not normal because the mandible, as the maxilla doesn't grow, the tongue has to go somewhere, so it sits on the mandible and it makes the mandible wider. So and maybe even position the mandible more forward into a class 3 bite. But I think the sooner we intervene and break that cycle of abnormal growth, the better it is for the facial development. We have the opportunity to change the size of maxilla today in adults without surgery. which is the biggest innovation that we have in orthodontics,
Hmm.
especially with the custom designs for adult male patients. But the mandible, if you want perfect mandible, start early. Don't wait until adulthood.
We were just about to sign off when Dr. Evans generously offered to show a few slides illustrating a point that she made during the interview. So, Doctor, I'm going to load up your slideshow and take it away. Why don't you explain to us what you're thinking?
Mhm. Sure. So basically, we had a question about early growth and development, epigenetic and genetic cause for maxillary deficiency. So honestly, the problem definitely, maxilla is very sensitive to environmental influences, and it could be a genetic problem. It doesn't help if you inherit deficiency from your parents, but also the problem can develop at any stage during growth, in utero or also during childhood. So maxillary deficiency can happen during childhood or in utero at any stage of growth. And this is a very nice study that I suggest for people that are interested in understanding the causes, that Dr. Yu from Penn Sleep Surgery, the department that I'm recently joined at Penn, wrote a very nice review on those causative factors that cause jaw deficiency, like softer diet, decline in breastfeeding, and nasal obstruction, pollution, that causes the jaws just not to grow, and then is definitely increasing the risk for sleep apnea. So when you look at this chart, it's very important growth chart for the upper and lower jaw. So the upper lower jaw are in green and blue color. You can see that they grow the most up to age 2, and then there is a plateau between age 4 to age 10 where there is growth, but the growth is not the same as before age 2. That's why that breastfeeding and properly weaning the child before age 2 and breathing through the nose before age 2 is very critical for facial development, because you do have adolescent growth spurt after age 12 in during puberty, but the velocity of growth is the biggest before age 2. So I just will show you two of my babies. So this is baby on one and baby 2. So baby 1, Stas, has a beautiful facial profile. This is his first day of life. And my
Wow.
second baby, Rome, has a very deficient mandible. Do you see that?
I do. I
Uh-huh.
do.
So when you have that deficient mandible, you get worried, because Rome has definitely decreased potential anatomically from day one for the lower jaw to properly grow as related to Stas, right? So this is just a live example for you.
Hmm.
So
Hmm.
this is Rome, who I was exclusively breastfeeding at 4 months. The middle slide is 4 months. Yes, he's sleeping with a little bit lips apart, but you can see that the mandible is now at the level of the forehead. So basically, the mandible is behind forehead in the initial, when day 1, when he was born. The mandible is already at the level of glabella, more or less, at the lab at 4 months, and then at age 2 you can see that the mandible is forward. Do you see the difference?
Yes, I do. He
So
grew. He grew well.
he grew well because we are trying to control the environmental factors. So imagine you take Rome at day 1 and you introduce the bottle, and the bottle displaces the tongue down and the mandible more back. That mandible is not going to grow. So if the child comes to me by age 4 or 6 with deficient mandible, like you see in Rome on day 1, there is not much I can do for that mandible. So that first 2 years of life are the most critical, and we cannot ignore or do nothing then. So we have to make sure that the child can breathe through the nose, can sleep well, can breastfeed as long as we can, and we can wean that child so he can eat harder foods from as early as possible, safe. You are not talking about choking risks. There are tools today that you can introduce those foods in a safe way to a child that allows that mandible and the upper jaw to grow. The lips are sealed, and the lower jaw has the best potential to grow forward.
Wow.
Okay.
What tools are those, doctor, that can help children wean directly onto tougher foods?
So the tools are the biggest tool. How do I stop sharing my screen?
I can stop sharing it for you. Yep. All set.
Thank you. So the tools are everything that we have been doing. It's basic. We got disconnected from the natural process here. We introduced bottles, we introduced pacifiers. So the tools are what we have been using for thousands of years. It's breastfeeding. It's not using the pacifier. It's making sure that the child is healthy and can breathe through the nose.
No, check for tongue tie, of course.
And of course, the tongue tie, the lip tie to allow the optimal nursing is part of it.
So Dr. Mew famously said 8 is too late, but maybe we should change that to after 2, you're screwed.
So it's interesting because if you have a child at age 4, and a lot of parents that come, they ask a question. My child is 4, very young. So what is the chance that they can still outgrow the problem? The chances, based on the chart that I show you, the chances are 0. If you have a problem at age 4, they're not going to outgrow it. It's not going to get better on itself. There is something that we have to do to make it better. We can change it, hopefully, a little bit for that mandible. For maxilla, it's reversible at any age. But the mandible has a window. And if you can do something before age 2, that's your best window. But if you can't, you can do your best after age 2, but there is a limit.
It's kind of sad and scary to think that so many of us are out to sea without a paddle, even as early as age 3. But hopefully, as my generation goes forward and has children, we can avoid the mistakes that a few generations now have made, and we can give our own babies the best possible chance. I'm actually having a baby in November.
Congratulations.
Thank you. Yeah. And she's going to be a little girl, and I'm really trying to get my ducks in order to give her the best chance to be healthy and beautiful. My fiance, soon-to-be wife, is very much on board. She's a huge fan of my channel, JawHacks, and listening to podcasts with people like you. So we're really trying to get it right. And that's why whenever I can, if there's a mother that I'm interviewing like you, I try to get as much information as possible about how to raise healthy children.
I know it's in today's environment, this is probably the most difficult thing to do. But in the same time, there is something that we can and have to do. And I can say that for the past 50 or 70 years, what we did was wrong. What we did is wrong, but it was just lack of understanding, and it was lack of information that the parents and the doctors had. So I think right now we are entering a new era of getting reconnected to the nature, asking a question why, because now we see the true disease coming to the surface late in life, right? Like sleep apnea and all the health issues that come along with that. So I think it's a good time in medicine, in dentistry, in our society to relook and make that change to as we don't have to go back in time, but we can actually do things to make this facial growth and development the way it was happening, as close as it was happening before we made all these convenience changes.
Right. It's like a renaissance where, Greek architecture and art was the best ever, right? But for 1500 years, it was lost and forgotten. And then in the 1500s, they remembered the original way of doing things perfect and beautiful, right? And then they reintegrated the ancient artistic features back into their modern world at that time, and they used modern technology to take it to a new level. So, and we call that period the Renaissance. So we're experiencing a renaissance now of natural health when it comes to facial structure, where we're getting back to our roots, but using all of our modern tools and systems and technologies to get there quickly and to figure it out right away, because it really is a crisis.
Absolutely, I totally agree, and it's a very exciting time because we need more podcasts like this to educate the public and also to learn from each other. And I think this is the time of inventing and reinventing our lifestyle and making all of these changes for better. That's for sure.
Yes. Well, thank you for the role that you've played in this, Dr. Evans, and keep up the good work. We need it.
Thank you so much. Thank you for your invitation.
Okay. Bye-bye.
Bye bye.